So, Ali, how was your week?
We've had a good week, haven't we? We had a nice little surprise. We received an email from Italy
Yes?
saying that our paper has been accepted for publication. And it's actually really exciting for everyone listening. I wrote a paper as part of my master's in clinical oral implantology. And Flo read the paper as a mentee and said to me, it doesn't quite make sense. That's fair, right?
I'm so kind, aren't
Yeah.
I?
No, and you're absolutely right. It was trying to cover too many things, but actually there was a core of a really cool paper in there. And I talked to the university about getting it published, and it was a lot of red tape. So Flo decided to make the paper make sense and submitted it for publication, and it's been accepted
Yes.
from the Journal of Osseointegration. So we're going to be publishing a paper together.
Yes, it was a little bit. I think when I said, "Oh, I'll help you with this. I'll do the admin side," I didn't quite realise the monster I was taking on. And there are every time for anyone who's looking to publish a paper, there is always another form you have to fill in. And I think what was quite lucky is the fact that it was just the two of us. I know I've spoken to people who do a lot more publishing, and they said that when you start getting into these teams where there's sort of 7 people and you're trying to chase everyone up for these forms, that's when it can get even bigger. But it's been a very interesting process. I feel like I know the old paper inside out now, even though
You know it better than I do, I reckon.
probably,
Yeah.
I definitely know when to pick when to choose the implant, whether it's a short implant or a sinus augmentation.
Yeah, and the cool thing was it was something that hadn't been done before. It was patient-specific factors, because it wasn't answering the question, are short implants better or sinus augmentation better in the atrophic posterior maxilla? It was looking at which patient and what is happening with that patient and how to choose. But I worked in clinical trials, and it was a big team, and it made me realize that when you offered to do the admin, it was a deal I had to take. And you learned nothing is for free, Flo. But no, it's great. It's awesome. This is it's every process you learn by. So no, great week. And in practice, it's been really busy with really cool stuff. And I think one of the coolest things that happened this week is I've talked about on previous episodes the fact that I've been working with Navident and Southern Implants to film a really cool surgery. And I went to go see the photographer and videographer Simon to look at the completed videos, and they look incredible. And we went off on a tangent, and he's now producer Simon for the show, which is awesome. Really cool guy and really knowledgeable. And yeah.
Yeah, big changes with the podcast. So lots of things going on there.
How's your week been?
Mine's been a little bit. I've done a lot of research this week. I know. You were taking the piss out of me last night when I replied that yes, I was sitting researching dental caries.
I thought you were joking.
I know. I wasn't. I was. I just sat down with the laptop. I realised basically where this has come from. I do like to sit and scroll a little bit through Instagram of an evening, and I had realised I quite often you get a lot of dental videos, and you hear all these different things. And what I'm trying to now be conscious to do is actually when I hear something and I find it sort of interesting, is to actually then go and find that research. That's sort of awesome. Yeah. So that's what I've been trying to do. So I saw that this video popped up where someone was talking about sort of making sure you're talking to patients, not about, oh, you've got decay, we're going to do a filling, but about dental caries is this non-communicable disease. Yeah. And actually talking about that lifestyle thing. So I wanted to actually go and see what the latest research out there on dental caries is. Because I think we're all you've got your script sometimes that you stick to, you've picked up things in dental school, but you don't then look at actually, has anything changed over the few years you've been out of.
I guess it's not the sexiest topic, so everyone's not keeping on top of it. Yeah.
Yeah, I mean, it's much sexier to look at implants or something than. But yeah, so I found that really interesting. Maybe we'll do an episode on some of that actual latest research out there, because there are a few little nuances, I think, in some of the language that's now being used, which would be interesting to discuss
Cool.
at a later
Yeah.
date. So a
Yeah.
little teaser there
Yeah,
for maybe
yeah.
something to come. But let's get on to what today's topic actually is, and that is dental scanners. I wanted to talk about this on the podcast because prior to this year, the year starting with you as a mentee, it's hard to, 2024 now, so prior to 2023, I'd never used a scanner before. They weren't mentioned really at university when I was there. I hope they are being mentioned a little bit more now. I didn't have access in my foundation or NHS job, and I was a little bit scared of them. The experience I had was I did sort of a university exchange program in China, and we got to have a little bit of a play out there. And then I had a friend who, when he graduated, went to private practice, and I went and did sort of an observation day, and he let me have a little go with his scanner. But other than that, I sort of wasn't that aware of them. So when I came here to actually start putting them into my dentistry has been sort of a massive change, and using them daily now, I think it's one of the biggest changes to my dentistry. For the benefit of listeners, just what a dental scanner is. I'm sure most people are aware, but it is a handheld wireless device used to scan a patient's teeth and gums. It creates an immediate 3D impression of the patient's teeth, gums and bite, and then you can view it chairside on a screen in real time, or it can be sent digitally to a lab.
So can I add a
Yes,
couple of
go.
things, Saf? I think you said wireless. Actually, a lot of them are wired, and I preferred the wired ones because anything wireless, you're depending on things like battery and connection. And the other thing is, when you said to me, let's talk about scanners, my mind went to, because we have 4 scanners as part of our protocol. So we have our Planmeca ProMax 3D CBCT, which is ultra low dose CBCT scanner, but we're not talking about radiography here. We have our intraoral scanners, and I think that's what you were referring to.
Yes.
We have our facial scanner, which is very much tied into our intraoral scanner. And then we actually, thanks to Darren Kelsey's lab up north, we've been using iMetric for our full arch work. So we've got photogrammetry as part of our scanners. But today we're talking about intraoral scanners.
Yes, I do want to touch on some of those other ones, but that main thing is that intraoral scanner. What is your sort of background in intraoral scanners?
So I was very lucky. I worked in a very forward-thinking practice at the beginning of my career. And my experience with scanners started with CEREC, but the old CEREC. So Dentsply Sirona's red cam and blue cam, which what we used to do is actually spray powder on the teeth and then take 3 photos that would stitch together and design and mill our chairside restorations. The practice also had the older version of the iTero, and that people using iTero now, I mean, it's sleek and it's small. We had a huge head on this iTero. I mean, I used to struggle to hold it up whilst I was scanning, yeah, and it was a little bit clunky, but incredible tech. And then the Omnicam came out from CEREC, which was color, lots of photos, moving around, a little more dynamic. And again, for chairside milling, that was great. And then I've played with various scanners when I was visiting practices. The Trios is fantastic from 3Shape. But you and I were at the ADI conference last year. And we've been talking about how do we do more facially driven treatment planning, because someone's teeth belong in their face, right? How do we do more facially driven treatment planning without having to really calibrate these photos so that they're in the right position, which Aston does an amazing job of. So he, through the Coist Center, he has his protocol with the Coist glasses, and the labs know how to calibrate, and it's brilliant. But it is an hour of clinicians' time, and it's hard work. And we needed to make it so that there's less error thrown in and it's much quicker. And we saw the facial scanner, the Metasmile from Shining 3D. And that was Mark, wasn't it? Mark was at the show. So Mark Barry from ESM. And normally when you go to a trade show and you're looking at an intraoral scanner, they use it on a model, and you use it and you go, this is amazing, right? But Mark got you to scan him.
Yes, and it was, we previously had the iTero here, which I enjoyed using, but once picking this up, it was just that speed and not having to go sort of back over some of the teeth and not having to be absolutely touching the teeth as well, and being able to do that at a show sort of, and he wasn't even laying back or anything like that. I mean, it was a little bit awkward doing it standing, but even then the scan that you were able to get was so much, it was quick, it was easy. Very good selling.
Yeah, no. I mean, but if someone can make it work in real time, you know it's a good product. Because we were actually there to try the Meta Smile, but this is the Aoral 3 that works in conjunction with it, and they kind of plug together. And also the size of the head, it was so nice and small. And I don't know if you feel like this, but from a sustainability point of view, the disposable heads on other scanners.
Yes.
From a business point of view, throwing away a £5 part of it it's not ideal, but I mean for the environment it's horrible. But because we are not tied to systems, because this is the issue, isn't it? If you want chairside milling or you're using a particular orthodontic system, you might have to be tied to particular scanners. But we were looking at an open market.
No, it was, and it's been fab sort of now actually using it with patients.
What have you found is the difference now?
I think one of the biggest difference is getting those back molars. For anyone that's sort of used intraoral scanners a lot, it's usually the bane is trying to get that awkward 7 or 8, particularly in someone that can't open quite as wide. And before it was really awkward trying to get a patient to sort of half close while you get sort of round that back bit. But with these you can, because the depth of field is you can be that little bit further away, it's just able to pick up everything at the back, and the head itself is a little bit smaller, so it's just that bit more comfortable. I think really, I mean, one of the best feedbacks, I've scanned my husband with both, and he was like, when you did it with that one, it was just so much more comfortable. And that speed. And I do know I've become more efficient with it in general, but actually I think using this, it is just that little bit more efficient there.
It's an interesting point you make though, because actually what we're doing is we're comparing our move to the scanner. But when a lot of people who are listening might be using conventional impression still, and so reflecting now on when you came to work with us, what were the biggest differences from going from conventional impressions to the scanner? Because you said your workflow is very different.
Oh yes, it is. And I think to begin with, it is that the first few you do, you're going to be slower, because when you're doing impressions day in, day out, you get quick, you can get them nice and repeatable. And when you switch over, it's suddenly like, oh, I'm very slow now, because you're not sort of used to some of that movement. But actually looking at it now, my speed is, I don't think it's quite as quick, just because you are having to sort of go round everything, but it's not far off from taking sort of a manual impression there. The thing that I love the most though now is being able to sort of reflect on that work in real time. Yes. It's being able to, on an onlay prep or a crown prep, zoom in and go, oh, actually that margin does not look as good as I thought it did in the mouth. And then because it's sort of all there, you can just pick the point you want to scrub out and redo it on the patient and only have to rescan that small part. Whereas obviously with an impression, I know you can sort of look in it, but you're not getting that same detail. And you're also not then, you're having to, if you are going to then change anything, you're going to have to retake it. Your nurse is going to get annoyed that they're going to have to mix something again. And
or you don't even know. Or it's the lab phoning you and then the patient having to come in again, right?
Yes, no, definitely all adds up. I definitely had a learning, one of my big learning curves was very early on. I was trying to be very conservative on an onlay, and I just hadn't left quite enough occlusally. And it's being able to have that part where you can click on after the scan and it tells you how many millimeters you've cleared. And that is just for me. So when you've got someone with an awkward bite, maybe a bit of an over eruption of a tooth, and you think you've taken enough, but you're that little bit short.
Or prepping sevens and you have over rotation once you've prepped it, Yeah, absolutely.
Yeah, for me, yeah, big advocate for an intraoral scanner.
And from a patient perspective, because we spend a lot of time thinking about the patient journey, a lot of people don't like having impressions taken. They have memories of all this goo in their mouth and the claustrophobia. So that's one side, but I find the really good side of it is being able to not just self-reflect, but also show the patient the scan. And there's, you bring them along for the journey, there's consent parts of it. So, I mean, it's just a no-brainer now with the types of scanners available and what it adds to your workflow.
Do you think that we should be scanning everyone almost as part of a yearly checkup?
It's an interesting question. I feel like I shouldn't have too much of a say in this because I'm not doing the yearly checkups. I think, with anything, having set rules, guidelines are one thing, but having these set rules, it can almost become like medical screening, which how helpful is it? I think it's great that like you and Aston are scanning people for tooth wear on a regular basis. I think that's of a lot of value. I think the problem is once you start introducing these things that have to be done that might not be of any clinical diagnostic value, what tends to happen is you're just adding to the cost and the faff.
Yes.
What situations were you thinking about?
I do think there could be some value because I think you never can quite remember something. Obviously, we can write notes and you can put a watch on something or let's monitor this tooth. But actually, if you were able to sort of go, we scanned you last year, it looked like this. We've scanned you this year, it looks very different. And it can pick up some of those minutiae. There could be a benefit to that. But
I think you've actually just convinced me. Because honestly, for the sake of 2 or 3 minutes, which actually you can scan a whole mouth in that time if you're efficient, and if the scanner's sitting there, what's the difference?
Yeah, I think, my would be sometimes that data overload, which I don't know if sometimes it might be, there's so much sort of then for a patient to take in or to deal with. But I do, maybe it's not yearly, maybe it's every 2 years.
Maybe it's not for the patient, maybe it's for us.
Yeah.
Maybe, because what we want to be able to do, I do it, if I look on an x-ray, let's say I've placed an implant, restored an implant, I take an x-ray and the tooth next to it looks like it has a faulty filling. I'll think to myself, did I miss something? So I go back to the earlier x-rays and I go, oh, actually, no, this has happened during this time. Phew. And actually having that there to inform your learning reflection audit, I think any tool that helps you become a better clinician, as well as provide better patient care, is great, yeah.
Oh, yeah. Maybe that's something for 2024 we start thinking to bring in then.
Well, what's cool is that actually in the practice that our nurses work at the edge of their scope of practice, right? So that means everything that they can do, they do. And impression taking is one of those things, and digital impressions. So we actually have one surgery that's dedicated to the nurses using it, and the nurses have their own list. And part of that is the intraoral scanning. So it could be part of the workflow where patients have their photos taken. They could also have a scan taken. I think it's a God idea.
Yeah.
Brilliant. I mean, I know that's not what this podcast's for, but
it's
great.
No, I do. It's great. The nurses are now going to listen and be like, oh, God, what's she done? More stuff there. What I did want to chat about, what do you think actually some of the cons are? Because I think it's very easy to talk about all the pros, but...
Off intraoral scanners?
Yes.
I think overall, intraoral scanners are a good thing. I think particular scanners have cons to them. So I don't like closed systems. I think the orthodontic landscape is going to change with, you having to buy a specific model of Trios or an iTero. There are other aligner providers that have come in. So I think being tied to systems isn't a good thing. But overall, I honestly can't see a con to them. It's a little bit like cars are a good thing. I know maybe let's park the sustainability thing for a second, but cars are good because they allow us to get to places. So this is allowing us to do something. It's just which car you need. And I think it's the same thing where I honestly couldn't tell you a bad thing about scanners. It's how you use them and what you use them for in the particular one you choose that will determine it. And this is the difficult part. It's a big investment for some associate dentists have their own scanners. So Sid is the first person I saw walking around with a Trios in a suitcase, like a door-to-door salesman, but not selling anything. But it's brilliant because he said, if I'm going somewhere, if I'm doing the job, I want to do it to this level, and I'm not going to ask the practices to invest in this if they're not in a position to. But for an individual or for a practice, it's a big investment. And so I think it's great that there's places like the IDDA, the Digital Academy, that have a scan club where you can read about scanners, but you can also look at buying one, and I think you get a diploma with them as well in digital dentistry, which is really cool. So there's no bad way to have a scanner. And there's lots of support out there now that there wasn't when scanners first came out.
Yeah. I do know one of the things I joined when I first started using, there's a Facebook group, it's called like the Itero Network, I think. And it's really good just for little tips, and people can put on sort of, oh, I'm having a little problem with this, do you have a tip? And I'm sure there are some Facebook groups and things for other scanners, but that was quite a nice, good way to start, just to pick up what other people are sort of saying, like, oh, I found this a bit awkward. Does anyone have any advice?
Yes.
Which is, yeah.
I mean, we looked at so many when we looked at scanners, and the problem with people's experiences is that often they don't have experience in lots of different types of scanners as well. So, essentially now, at one point, the Medit came in and it disrupted the market because it was priced as an entry-level scanner, but it did everything and had open software. And then as it became more popular and people realized it's actually really good, it's just priced low, the price crept up. And now I think the Intraoral 3 has come in and is kind of taking that mantle. But because it's a worldwide thing now, it's not just markets that can afford it, it's a lot of the world are using scanners. The support is just phenomenal. I think the first groups came out of Australia for CEREC support, and now there's international communities of it. And the support now with multiple companies means that if you go into scanners and you take that journey, there's so much support out there.
Yeah, oh, definitely. I mean, I'm very lucky. I've got you and Aston in the building that I always hit up for, oh, what do you do for this? I mean, one of the sort of those looking at what is more difficult to scan, sort of that whole soft tissue. And I know you've got a little tip that you do on sort of soft tissue.
Yeah, so tissue marking pens, draw a pattern like a ladder on the palette, and it just helps you stitch it together. I mean, you can use anything. You can use the, I always forget if it's the catalyst or the base from calcium hydroxide, but anything that you can paint on, it just gives you something to stitch across.
Yes, and yeah, that's been really useful. With the other big one is sort of that shiny, when you've got some very shiny amalgam or shiny crown or something. And I know sort of what we're using, there are modes you can sort of put it into, which is great.
Basically using AI.
Yeah,
it's incredible.
But if you don't have that mode, it is just, making sure the lights are out, making sure everything's dry. That's always going to help it pick everything up there as well.
I mean, I think you have to go through the journey of realizing, switch the lights off in the surgery, hold it on this part first. But the big thing with all scanners is they all have a specific scan pattern that you're meant to follow. So you have to learn how to use your scanner. You can't speak to your friend who has another scanner and say, how do you use it? And they tell you about it. It's system specific. And I think when people realize that, they realize all the scanners are very good. You just might not be using it well, and it might not be great for what you need it for.
Yeah, and it's also, I think, sometimes in your hands. So it also might be a very good, you might actually be using it right, but it's just not for you. And it is the luxury of, if you are working multiple practices and can try multiple things, or when you're at a show, actually going and having a go with different ones and seeing what feels right for you. I know, I mean, being female, a lot of the world has been designed for men. There's a great book on it, looking at all sort of the data, but some of the scanners are bulkier to hold. And if you've got very dainty hands,
like mine,
it is a bit more awkward. So it is worth actually holding them. Like you said, some of them, if they're that heavier and you don't have sort of that massive bicep going on, you might want something that is just a little bit lighter for that day-to-day scanning.
So actually, that's a really good point, that actually a scanner is probably not something you should buy off of doing research and reading things and speaking to people. The value of trade shows is huge, right? Conferences, trade shows. I mean, to be able to go and pick it up and try it. Now, if the big tip is, if someone lets you try it in their mouth, it works. That's what happened to us,
Definitely. And it's talking to the reps, and as you said, getting them to actually show you the order that you use it, show it how they've tell you to use it there. It's going to be massive. What I did want to talk about is actually what I know you've sort of touched on it a little bit earlier, but what your workflow is for implementing not only that intraoral scanner, but that facial scanner, the CBCT.
Yeah.
Sort of, do you have a case at all where you could talk through that workflow?
Let's talk about full arch for a second for implants, because this is what I'm really excited about. And I'm working with Navident, who are based in Canada, on a new workflow that's fully digital. So I know this may not be bread and butter for a lot of people listening, but it kind of summarizes it, I think, well. Especially with full arch, we're redesigning someone's occlusion, their face, their smile. So we get a facial scan and an intraoral scan, and those stitch together. So at that point, the lab have their face and their teeth inside and how it all sits together. And we take a CBCT, so a 3D X-ray low dose, that stitches into that as well. So we have the bones, the skin, the smile, the teeth all in one. The smile then and the new teeth get designed around that. And we can take into account the lip line, which is the most important factor when we're treatment planning, in my opinion, in most cases, because you can't hide any sins in a high smile line. And so we can work on this.
A little bit of Botox.
Yeah, I mean, you can't, and then you can see, you know, it's Flo will sell you that every 3 months. No, and you know what? No, I joke about it, but if we can avoid, good treatment planning can help to avoid a lot of subscriptions to things, is the idea. And then when we plan the smile, we can plan the surgery backwards from the smile. We can transfer that to Navident at that point, and we can place the implants exactly according to the final plan. And so we've made, I equate it to building a house, where you don't just start putting bricks down and see where you go, right? You get the architect's plans and you work backwards from it. And the beauty of this workflow is we don't have to have any physical lab work until the end. Now, once the implants have integrated, we use photogrammetry, which if you use iMetric is accurate to about 5 microns. Traditional methods of conventional impressions in full arch implants, if you follow them really well and you have a tiny bit of luck, you can get within 100 microns, which is accepted, but it takes a lot of steps. So 5 microns is phenomenal in 5 minutes. We've actually got 2 cases in today we're going to use it on. And that means the lab can go straight to fabricating the prosthesis. So the amount of time you're having to spend on this decreases, the accuracy increases, patient outcomes increase in terms of delivering what you promised, so the consent is great, but we can start to bring the cost of these, once the machines are paid for, we can bring that down so that we can make this accessible to more people. Because the key is, we want to be able to deliver quality of life. That's our privilege as clinicians, right? I'm getting a bit excited about this because I do get excited about this. So I think the digital workflow, you might start with an intraoral scanner, but there's so much you can do. And actually, when you bring it all together, it changes the journey.
Oh yeah, and I for the patient as well, I just think that comfort level on top of it, and how repeatable every step is, just...
I feel bad for the postman, because what I say to the patients is, they go, oh, you're not going to use that goo. If they're referred in, they've had conventional impressions. Oh, I don't like impressions. Oh, we're taking it digitally. And I always say, and it's kind of part of my pattern, it's probably Postie's not going to like me, but I always say, well, you see your impression, the postman could kick that around and it could get distorted, but this gets emailed off. And it's another thing, I mean, it's such a small consideration, but postage takes 2 days. Forget the environmental effect, the actual delay to lab work. We email it off, it's accepted, we know it's dimensionally stable, we know we've checked the accuracy of it, and we know if there's a problem, we can repeat the scan, overlay it, and we can pretty much figure out the issue, which diagnostics, when things are going wrong, what you don't want to do is to just keep redoing things in the hope that they'll be better. It's frustrating for the lab and you. So in terms of increasing our efficiency in having great lab work every time, it's made such a big difference.
Definitely. So I put out a little call out to the listeners for some, if they had any questions at all that they wanted answered on scanners. We've got a few questions back. First one, what are sort of the extra features that are available with scanners?
Cool. So I think with software now, there's a lot more you can do. I think what's really cool is a lot of them have the AI mode you can switch off that gets rid of soft tissue if you want to be doing dentures and things with your scanner. So that's pretty standard. Ours is really cool because we have a metal scanning mode. So it's actually easy to pick up whether it's metal crown and bridge work or scan bodies for implants. That's really, really useful. I think I might be wrong. I'm not an expert in this, but I think now a lot of them have caught up. Can you think of any features?
So I know there are tooth wear monitoring sort of on some of them, so you can sort of very easily overlay them and you can see the micron millimeter differences. The caries detection
Yes.
is not something I've sort of used much of, but I definitely would be interested to start playing around with that and sort of seeing
How it works.
how accurate that is. But I reckon that's probably coming in a lot more, particularly with more of the AI on radiographs for caries detection as well.
Yes.
If we've got that technology, we might as well be using it, even if you're not completely relying on it, but having that as an adjunct.
I think that's the key. The key is all of these things, they're based on algorithms that are based on something. They're not testing for caries.
No.
They're not taking a little scoop and putting it under a microscope. But yeah, absolutely. The more tools we have, the better.
Talking actually, next question from Emma says, what are the limitations in making a denture with a scanner?
Cool question. Right. So I believe it might have been one of the first dentures off of a scanner way back when I used the CEREC Omnicam to make a peak framed denture. So it's the equivalent of a chrome for someone who had a really bad gag reflex, and it was a phenomenal fit and looked amazing. And it was Burns Dental Laboratory in Oxford. Ashley's incredible and his team are amazing, and they made a really good denture. Now what I'm finding is it's become more common to make 3D printed dentures. The problem is, it's often not the scanner that's the issue. The lab have to not just have great equipment, maintain it well, they have to understand how their materials work that they put into that. So Aston's definitely the person to ask about this more, because obviously you can't do mucocompressive techniques with this. But as far as I can see now, for what I do, which is not complex denture work, it's temporary stuff most of the time. I don't take impressions anymore for dentures. Have you made any dentures off of scans?
Only sort of that temporary variety. I think for me, I'd still be skeptical to sort of be using it as a permanent denture, just because there are slight limitations. Again, that mucocompressive, how sort of accurate sometimes, sort of getting further back. I still think there maybe is a little bit more development on that soft tissue front that I reckon is coming, but we're maybe just, a year or two away from some of that detail there. And again, there's a little element of the operator, that if we're not doing it all the time, whereas if you are very good at taking conventional impressions, like Aston is, and he has a whole process with it.
And his lab are aligned with that process.
And that's then you're going to get that much more repeatable, predictable result.
I'm going to put something out to the listeners, actually. Here's a challenge. If you've made any digital dentures, send us a photo of the coolest digital denture you've made, and we can share a photo of the coolest one that gets sent in.
Yeah, I like that.
Because I'd love to see what's out there with digital dentures. Amazing.
Very hard to say, though. Digital denture.
I'm eating those words,
Last question that came in, and I think it's a little bit of an awkward one to answer, but what are the cost differences between sort of taking a conventional impression compared to a scanner?
Okay, so I guess it depends on a lot of factors. I was always told, and I'm guessing the price has gone up or this was inaccurate, but taking a putty wash impression costs about $5. If you're using iTero, each disposable head costs about $5. So you got to think of the machine costs as well, right? I think the answer is the more intraoral scans you take, the cheaper it gets, especially if you have an autoclavable head. And I think that cost is maybe, obviously the outlay of the machine is big, but I think cost per impression shouldn't be a factor. Also in dentistry, I mean, we're splitting hairs about something that's so important. I know that's not entirely helpful.
Well, I think it's very hard to actually put numbers on it, because actually when you start playing into, if you've got nurses taking the impressions, then the time you're saving to do other things, that's got to be factored in. That lab turnaround time, how many are you having to repeat? Are you having to pay again for a crown? Postage costs, sending it, if postage goes wrong, all of that. So it's very hard. I mean, you can look very at the minutiae materials. And I mean, with digital, you do need to think about electricity to add that in.
I mean, but the big question is, what price are you putting on your learning and your consent process from that? And also, when you're doing your prep analysis and you realize, I haven't been working with bad dental technicians who are over contouring my restorations. I've been under prepping my restorations. I mean, the value of learning that early on and delivering better dentistry, I just don't think that comes into it.
Definitely. I think as well is that if patients like it and you actually can get growth from it, that's also a massive factor that's going to pay in financially. The big thing I think with scanners, initially there's going to be a big cost, and your efficiency isn't going to be there. But actually, once you start looking 3, 4, 5 years down the line, I think it's going to flip.
I completely agree. It's about the long-term view.
Yeah, definitely. That's all the questions we have from the listeners today. If anyone has anything that they want us to discuss further, any topics, or if you've got any more questions on scanners, we can always answer them in a later episode. Please DM us at Pearls Dental Podcast, and we'll get back to you there. Thank you for your time today, Ali.
Thank you. And I just wanted to add that this episode, for the people listening, will be available on YouTube, and we'll share the name of the channel. And producer Simon will be in charge of that. So any tomatoes to throw, send him his way.
Fab. Thank you. Yeah, thank you for everything.
Thank you.
Ali, why did you invest in the Navident dynamic navigation system?
It's incredible. It brings our safety and accuracy up for patients. Here's a tracker that we use. And thanks to Rob from the Dental Imaging Company, it's been great support and so easy to set up. I see why so many people go to him for their digital imaging, 3D or 2-dimensional. And also all their surgical supplies like Ustamed screws. Rob's been incredible, and I'd highly recommend working with him.
Ali, why do you use Southern implants?
I love these implants. Brilliant. I have options like coaxis, which 38% of implants that are used by Southern are coaxis, which means that 38% of the time, if you don't have coaxis angle correction at implant level, you're compromising on your treatment plan. On top of that, soft bone implants for the pterygoids, as well as the max implants, immediates for molars, can save having zygomatic implants. Definitely the way to go.
Ali, can you name everything in the practice that's made by W&H?
Ooh, off the top of my head, all of our handpieces, our sterilization equipment, my implant motor, the PiezoMed, they're an incredible company to work with because they're an Austrian company that focus on hygiene, and we know from studies that patients care most about hygiene. To top it all off, the support we get from them is amazing. They don't actually supply the equipment, but they provide the support. Now that's true support.
Ali, what's that you're holding?
Well, this is a burr box from Crown Dental Burrs, and it has Dr. Flo King's name on it. And the reason we've implemented this in the practice is that Paul has the rota system, so his great burrs are kept in order. That means you can ask your nurse for a number of burr, which means you'll always get the same burr, and the rota system means you'll never run out of burrs. So it's definitely worth the investment, and it's not nearly as dear as you might think for something this good.
Thank you for listening to Pearls 2 Generations in Dentistry. Don't forget to follow us on Instagram at Pearls Dental Podcast. Send us a DM with any questions, queries, or topic suggestions.
And remember, you can watch our episodes on YouTube. Please rate and review the podcast.